Good morning. My name is Donna Berta. I'm a nurse with ORBCON, the Ontario Regional Blood Coordinating Network, and today I'm going to be talking to you about solvent detergent plasma. Is this wash plasma or? I don't have any commercial product conflict of interests. I am a member of several transfusion-related committees. We're going to begin by looking at 3 questions about SD plasma. The transition to pathogen-reduced or solvent detergent SD plasma, octoplasma, provides an additional layer of safety to Canada's blood supply. This additional safety includes A, decreased risk of allergic transfusion reactions, B, inactivating all viruses, C, inactivating all bacteria, or D, this is a pooled product and patient or recipient blood group is not relevant. I'll give you a moment to consider those choices. Hey, interesting results here. And we will come back to this question throughout the talk, and again at the end, we'll review the questions. The second question, Emma is a young female trauma patient in your eMERGE. MASH of hemorrhage protocol is activated. We don't have a blood group and screen test result at this time. Select the plasma, including SD plasma, blood group to be transfused to Emma. A, group O, Rh positive, B, group O, Rh negative, C, group AB, Rh negative, or D, group AB, Rh is not relevant for plasma transfusion. And again, this is plasma that we would be transfusing. So I'll give you a moment to select your response. And again, the majority is here. Interesting result. We'll come back to that. And the final question, when transfusing SD plasma, visual inspection of the product is not necessary. Some particulates or clumping is okay. It's compatible with all IV fluids, saline, dextrose, ringers. You should use standard blood tubing with a 170 to 260 micron filter. You should infuse it as quickly as possible. The half-life of coagulation proteins is less than 30 minutes. I'll give you a moment to select a response there. Okay, pretty strong agreement there. Again, we'll come back to these topics throughout the presentation, and we will address the questions again at the end. So just to put plasma transfusion in a bit of perspective, this data is from the Ontario Regional Blood Coordinating Network, their hospital site visit data, and this is based on transfusions from April 1st, 2022 to March 31st, 2023. So in Ontario, every day, about 953 units of red cells were transfused, 160 platelet doses, and 109 units of plasma. And this would not include cryo or SD plasma. It's tabulated differently, and I don't have access to those results. But at this point in time, up to March 31st, 2023, SD plasma would not be widely available for all patients. So I feel this number is generally reflective of our plasma usage in Ontario. So just to put this into context, plasma, yeah, it's transfused some, but it's certainly not the most common blood component to be transfused. So our learning objectives for today, for you to understand the unique features of SD plasma and its clinical indications, and also some nursing actions to give this product as safely as possible. I do want to point out that the presentation provides evidence-informed information. It's based on interpretation of the transfusion medicine standards and best practices. But again, you're working within your hospital, and so your policies and procedures need to guide your practice. An outline of what we're going to cover, various aspects of plasma, And we'll start with talking about what is plasma, what's different about SD plasma, and why is this happening now. So plasma, and this link goes to the Canadian Blood Services product monograph about plasma. And the product monograph at Canadian Blood Services is called the Circular of Information, so it will take you there. Plasma, it's the liquid part of blood. It contains the coagulation proteins that are needed for the clotting process in order to stop bleeding. And this link takes you to some more information about the clotting process. We're not going to discuss that at any length today due to the time constraint. Plasma as well is stored frozen because that does preserve the level of the coagulation proteins. And these 2 points, they are the same whether we're talking about plasma from CBS or SD plasma from Octapharma. So Canadian Blood Services traditionally has manufactured frozen plasma, or FP, and that's collected from a whole blood donation where it's centrifuged into the 3 components, and then the plasma component is frozen within 24 hours. Canadian Blood Services also provides us with AFP, or apheresis frozen plasma, that's collected by apheresis techniques, where the donor is hooked up to the apheresis machine and just their plasma is collected, their platelets and red cells go back to them. And that product is frozen within 8 hours of when it was collected from the donor. These 2 products that Canadian Blood Services provides do have similar levels of coagulation factors. The major difference would be the volume. FP volume is about 289 mils on average, and AFP is 249. For the rest of the talk, I'm going to refer to FP, but again, they could be used interchangeably. So what's different about SD plasma? And this link will take you to the SD plasma product monograph. So it's made from large pools of plasma, anywhere from 630 to 1,520 plasma donations. They are pooled based on the ABO blood group, so it has to be all the same blood group. So each bag is labeled with its specific ABO blood group, so it is blood group specific. It does undergo a pathogen reduction process. So there's solvent detergent agents that are added, then those agents are removed, and then there's a sterile filtration process. So lipid envelope viruses, not all viruses, but specifically lipid envelope viruses are inactivated, leukocytes are depleted, prions are removed. This pool of plasma that we have, it's divided into precisely 200 milliliter individual units. So all SD plasma units have the same volume of 200 mLs. The clotting factors levels are similar to FP, except with the exception of protein S and antiplasmin levels being lower. This pooling process from these many donors, that will dilute any antibodies, allergens, or cytokines that are present in one individual donor. And so that decreases the risk of allergic reactions and also of trolley. The important thing to remember is that FP and SD plasma, the clinical indications are the same. There are some differences, and that affects hospital practice, both in the transfusion medicine lab, TML, and for transfusionist people administering the products. And that's what we're going to focus on for the remainder of the talk. Why is all of this happening now? Well, in July of 2022, Canadian Blood Services announced their plan to transition to pathogen-reduced platelets and plasma. And that was to provide us with an additional layer of safety in our blood supply. This is in addition to the donor screening and testing that happens with each blood donation and continues to happen. SD plasma has been used in Canada since 2011, and it has been restricted to certain patients, and that would be patients who are undergoing plasmapheresis treatment. And of those plasmapheresis patients, it would be patients who had significant pulmonary comorbidities or they had experienced allergic reactions to FP. So it was an approval process that was required to get SD plasma for patients. CBS did have a plan for this transition, and that phase 1 was that by September of 2023, 80% of all plasma would be SD plasma, so that 109 units per day across Ontario, that would decrease by 80% by September. I'm not sure how close to that target they are. That is not known to me at this point in time. And then their second phase was that additional 20% of FP, CBS would undertake a pathogen reduced technology, the same as they use for platelets. And the timeline for that is somewhere 2024 to 2025. So this is what it looks like, SD plasma. As you can see, the bag does look smaller. Its volume is lower, and it does have this plastic overwrap. Again, the clinical indications are the same. It's the differences that we're going to talk about that will make some practice change for you, and also in the blood bank. So we're going to move on to talk about clinical indications, transfusion guidelines, dose, and compatibility. So we'll start with a question. Flo is a 69-year-old lady who had a major heart surgery 48 hours ago. During the operation itself, she received 8 units of red cells, 4 units of SD plasma, and a dose of platelets. She's doing really well now. She's just on a little bit of oxygen. Her vitals are stable. Her chest tubes are draining very minimal. Her lab results, her hemoglobin is 78, platelets 88, and her INR is 1.5. So her doctor orders to transfuse 4 units of plasma, each over 1 hour, 30 minutes post-transfusion, recheck her INR. So my question for you is, this is an appropriate indication for plasma transfusion, and you can select yes or no. I'll give you a moment to do that. And most of you selected no, and I would agree with that. We'll go on to talk about the indications. So this is a summary of indications based on the Canadian Blood Services Circular of Information, the SD plasma monograph, Bloody Easy 5.1, and also the information that the National Advisory Committee on Blood and Blood Products, known as NAC, has put out about plasma. So plasma, FP and SD plasma, are indicated if the patient is bleeding or they're going to have a significant operative or invasive procedure. Their INR is greater than or equal to 1.8, and there isn't any other coagulation factor, concentrate, or other therapy that's available, or those therapies would be contraindicated. Plasma transfusions indicate if there's bleeding, major bleeding, massive bleeding, in a massive hemorrhage protocol has been activated, and the patient is very unstable and you can't wait for INR or PTT results. And there are some other very specific indications for plasma as well. It's important to remember, in the scenario of abnormal coagulation test results, like an abnormal INR, in order to determine if plasma is indicated, you have to look at the cause of the elevation. So that's an important factor. And that's partly because INR, that test was not designed to measure bleeding risk or potential for bleeding. It was designed to measure the body's response to warfarin therapy. And so it's kind of like a surrogate measure for plasma transfusions. It's not quite the same as we use hemoglobin to guide a red cell transfusion or platelet count to guide the need for platelet transfusion. So the INR is a bit of a surrogate marker, but it is what we have available and what we do use. Some additional notes: liver disease patients, they are a special population, and that's because all of the coagulation factors, the naturally occurring factors, both the procoagulant and the anticoagulant factors, are produced in the liver. And so liver disease patients kind of have a rebalanced hemostasis. So sometimes they don't need correction of the abnormality. Plasma shouldn't be used to treat hypovolemia. If the INR is less than 1.8, it's not indicated. If the patient's not actively bleeding, it's not indicated. And it shouldn't be used for reversal of heparin or low molecular weight heparin, warfarin, or the direct oral anticoagulants. There's other products that are better. An additional note, SD plasma, you can give it at the same time as FP. That's perfectly fine to do. So if we go back and look at our patient flow, her INR is less than 1.8, so that's not an indication for plasma. And she is not actively bleeding, so there isn't really a good indication for plasma. I'll also point out at this point in time, there is an SD plasma contraindication. Patients with severe protein S deficiency, they should get FP, not SD plasma. And that's because in SD plasma, there are the protein S level is significantly lower, and that may lead to an increased risk of blood clots. So we'll go back to Flo's order here. And we note now that her weight is 70 kilos, and this dose, 4 units, is that an appropriate dose for plasma transfusion for Flo? And I've given you the choices here of yes, no, or possibly. So I'll give you a moment to reply. And many of you have picked up on the possibly option or the no option. And we'll discuss that a little bit further, but I would favor possibly or no. So in terms of dose, the CBS Circular of Information on FP says it depends on the clinical situation, patient size. It recommends a dose range 10 to 15 mils per kilo. The Octapharma product monograph says it depends on the clinical situation and the underlying disorder, so fairly similar, and recommends a dose of 12 to 15 mils per kilo body weight, and also indicates that that will increase the plasma coagulation factor levels by about 25%. Our historical practice, and in most hospitals, the plasma order set, I would suggest that they usually would recommend the order be in units, and for a large adult, 4 units, a small adult, 3 units. So it is a bit of an unusual situation where we have a mil per kilo recommended, but we're dispensing or issuing based on units, because for adults at least, we don't divide units into the specific milliliter calculation. We don't waste the plasma. Again, I will point out that the information that I'm going to present next, you should still follow the policy established by your transfusion medicine service, but you may want to ask them to consider some of this information. Bloody Easy 5.1 has said for massive hemorrhage protocols, the ratio should be 2 to 1 for red cells to plasma. And they do also provide in Bloody Easy 5.1 a table with 5 kilo weight increments and dosing in mils based on the 10 mil per kilo or the 15 mil per kilo. But it's still, you just get that mils. It doesn't really tell you how many units that you would need. NAC, just back in October, has really stepped up and provided us with some concrete information and suggestions. They do say for the indication of correction of abnormal coagulation test results, so INR, they give us some very good suggestions that are very practical, like we should use order sets and we should have the dosing information within the order sets, and we should have policies for our blood bank to substitute FP for SD and vice versa. They also give us 2 example tables. The first one has fairly significant 15 to 20 kilogram weight increments. It's simpler and smaller, but I'm going to show you the second one, which I favor, on the next slide. And NAC has also indicated that there's going to be some more information coming from them, hopefully fairly soon in December. This is the second table that NAC has provided. And so in this table, they have weights, they have weight ranges of 5 kilos, they have a 10 mil per kilo volume, and that is based on the higher weight of the weight increment. They also have a 15 mil per kilo volume, and that calculation is based on the lower weight of the weight increment. And then they've gone on to round that off into units of SD plasma or FP. And that's based on an average dose of 12.5 mils per kilo, that rounding. They also go on to recommend that if the weight's less than 40 kilos, you should do the dose calculation and give that number of mils. They've also put a cap on this table at a weight of 100 kilograms and suggested that anyone who's 100 kilograms or greater, that should be the limit. And so for Our Lady Flo, she weighs 70 kilos, so she would fit into this line. And we can see for SD plasma, she may need 4 to 5 units, depending on how high a dose you would want to give. Or if it's FP, she would only require 3 units. So that possibly answer to our question is probably the correct one. I do feel strongly that this is a very useful table, and it really provides a lot of guidance in terms of dosing plasma, and that blood banks should be looking at this information and reviewing it with their transfusion medicine physicians and transfusion committees to really consider this. In terms of neonates and pediatrics, there's not a lot of data available, and NAC has basically said there's no reason to expect any differences. Go ahead. Bloody Easy 5.1, again, just reinforces the dose for pediatrics, and that's really all that I could find out there. We'll come back to Flo again one last time. Her order said, even though we said it might not be the right dose, it's not a good indication, but her order says to 30 minutes after the transfusion, recheck her INR. So to assess the response to plasma clinically, to assess the response to plasma, should we be doing a clinical assessment and repeating the INR 30 to 60 minutes post-transfusion? And you can select yes or no there. And the majority have selected yes, and yes, that is correct. You should reassess the patient clinically to see if they're bleeding or not, and you should recheck your INR. That is the recommended time frame within 30 to 60 minutes after the transfusion, because that will give you guidance in terms of what your pre-INR was, in terms of how it's responded, how the coagulation factors, the increase by transfusing the plasma has made the patient less coagulopathic. We're going to move on now to another case, and this case is 100% fictitious. I'm presenting it just to discuss the administration of plasma, and certainly I am not an expert by any means with liver disease, and so this doesn't necessarily reflect a current treatment standard. Nonetheless, we'll talk about Freddie. So he has cirrhosis of the liver. He is on the list awaiting liver transplant. Unfortunately, he had a fall, he's fractured his hip, he needs surgery, hip replacement, reconstruction, big surgery Freddie needs. His weight is 80 kilos. His lab results, all that we're going to focus on is the INR, and his INR is 2.5. So his physician orders transfuse 4 units of plasma each over 1 hour, 30 minutes post-transfusion, recheck his INR. So that seems pretty reasonable for this scenario. For this plasma transfusion for Freddie, he requires a blood group test, yes or no? And again, I'll give you a minute to consider that. And the answer here is yes, and yes, indeed, plasma should be ABO compatible. So we do need a blood group test for Freddie to give ABO compatible plasma. So this is a standard compatibility table. Every hospital has one, and patients should be transfused plasma that's ABO compatible with their own red cells. Plasma, depending on the blood group, has anti-A and or anti-B antibodies in it, and that could hemolyze the patient's own red cells if they have the corresponding antigen. If you want more information about compatibility, there is a link to some compatibility information here. We're not going to discuss that at any further length. But you can see for plasma transfusions, regardless of the patient's blood group, AB plasma appears throughout. And so AB plasma is the universal plasma that can be given safely and is compatible for any patient of any of the 4 blood groups. A note on RH. RH blood group is not relevant for plasma transfusion because plasma is non-cellular, so there's no antigens there. So the patient's RH is not relevant for plasma. We just have to look at ABO group. So for Freddie, his ABO blood group is O. So his first unit of plasma is still not ready. It's been almost an hour since you saw his ABO blood group test result in your lab system. So as his nurse, you should call the blood bank to find out what's taking so long. And I'll give you some choices there: yes, no, or possibly. And we have a bit of a mixed response here. And at this point, with this amount of information, I would probably go with the possibly. I mean, if the OR is calling you saying, we're ready, we want to get this surgery going, yeah, then for sure you should call and find out, because we need to look after Freddie. But if Freddie's pretty stable and the OR doesn't have a time frame in mind, then you might want to give your blood bank a little bit more time, because preparing plasma can be a little bit complicated. And that's again because whether it's FP or SD plasma, both are stored frozen. SD plasma can be stored a little bit longer frozen, but they both have to be thawed. And standard for thawing FP, blood banks have been doing that for years, decades, takes 20 to 30 minutes. For SD plasma, the guidance in the monograph says not less than 30 minutes, shouldn't be longer than 60 minutes, and it should warm to 37 degrees body temperature before you infuse it. So a little bit more involved with thawing SD plasma. If you already have some thawed, once it's been thawed, FP can be put in the fridge and kept for up to 5 days. SD plasma, the monograph also says that, but there is further information to say that it should be thawed shortly before use. And pre-thawed long-term storage should only be an exception where time is critical, like in a massive hemorrhage protocol. So if SD plasma has been put into the fridge after it's been thawed, there is a little bit more involved, and we'll talk about that when we talk about visual inspection of plasma in a few slides down the way, because you'll see what I mean, what I'm referring to there. So in this case, you may want to call blood bank, or you may not want to give them a little bit more time to see what's going to happen with Freddie. So now we're going to move on and talk about administration checks. So what do you need to do when you're checking plasma? So we'll again talk about Freddie. So blood bank has now issued SD plasma, blood group O for him. And when you're checking this SD plasma, the product lot number, that's what you should be verifying as identical, and that should get recorded on Freddie's health record. And you can reply yes or no to that. I'll give you a few moments. And most of you have replied yes. And yes, there is a number that you do need to check for SD plasma. However, it's not the lot number like other manufactured products. SD plasma has a unit number, and we'll go on to talk about that unit number. If we're talking about administration checks, there's a few key points that I just can't not state. So when you're checking blood, make sure what you get from the blood bank aligns with the order. Patient identification is critical. The identifiers for blood transfusion the patient identifiers are surname, first name, and unique identification number. That's what the standards say we should be following. The patient has to be wearing an armband. The patient identification has to stay attached to the blood during the transfusion. And so checking blood 4 steps, same 4 steps for plasma: patient identification, and I have in a smaller font listed where you find that information: ABO blood group, unit number, expiry, and visual inspection, those same checks. We're not going to go through the checks in detail, but we're going to look at Octapharma labeling and what's important to pick out there when checking it. So this is our bag with the label, and I've just enlarged it so we can look at it a bit more closely. So Octapharma does give a lot number for each lot or batch of SD plasma that they make, and it's listed here. But SD plasma, unlike other manufactured blood products, it does have a unit number that's unique to each bag of SD plasma, and it starts with an X. And it's listed here on the blood bag label, similar to where we find the unit number for the fresh components that are manufactured by CBS that start with the C. There's also there's lots of barcodes. There's a barcode for the product name, and that's already also written out for you, Octaplasma. There's a blood group barcode that's here, and it's also written. This is a blood group O unit. And then there's a barcode for the expiry date. And the expiry date is also written here as well. And so the expiry date is the date of production plus the 48 months that it can be stored frozen. So your blood bank may thaw the plasma, and you may just get it with this label, or your blood bank may also reprint a thawed SD plasma label. And that would be specific to hospital blood banks, what they do. This example of a thawed label, it again has that unit number on it that starts with the X. It has the product barcode, and also now the product is thawed solvent detergent pooled plasma. They've handwritten the volume on, that's what they do at this particular hospital. The blood group barcode is there, and it also says the product's blood group O. And then the expiry date barcode, and actually the written expiry date, it appears here, and it is the date and time of thawing plus 5 days or 120 hours. So in this example, this unit of SD plasma was thawed on November 14th at 8:40. Whoops, sorry, apologies. Get the right slide here. So we've finished with that one. And now we'll move on to the transfusion label. So this is the label that your hospital puts on the bag of SD plasma. And so this label, it lists the patient's surname and first name. It lists their unique identification number, tells you what the product is, thawed solvent detergent plasma. It's got that unit number that starts with X. It also has the patient's blood group that is pulled from the patient's group and screen test results. And then it has the unit's blood group that's pulled from the Octapharma label. And in this particular hospital, they also put an assigned time on it. So this is when, and the MLT's name. So this is when they assigned it to the patient. This is the chart label from the same hospital. Again, I apologize for the less than ideal copy here. And it basically contains all of the same information that's on the blood bag. This is the form that would go on the patient's chart. So the expiry time, in checking that, the time that you need to complete your transfusion by, for FP, we know it's been standardized to be 4 hours from the time it was removed from storage, or 4 hours from the time of issue. For SD plasma, the product monograph, again, because this is a manufactured blood product, it's within 4 hours of spiking the bag, just like IVIG or albumin is within 4 hours of spiking the bottle. It needs to be transfused. SD plasma also has additional information that it can be stored for up to 8 hours at room temperature before it's used. So in my thinking, for ensuring transfusion safety, the transfusionist really needs to know the issue time, the time it was removed from the temperature-controlled environment for both FP and SD plasma. So that's something that you would want to look at in your hospital in terms of what's on your labels and where you get your information in this particular hospital, with the examples I've given you, their issue time is documented in their computer system. But you may want to look at what your hospital does. And please remember, this is an evolving process in terms of bringing in the SD plasma. So it might be something that's a work in progress. And now the last part of checking, the visual inspection. So this is some thawed SD plasma, and you can see here there's some clumps, it's a bit cloudy, there's some particulates in here, and that's all fibrinogen. This example over here, these little black dots, that's denatured proteins, and that would be related to the product being at too high a temperature and too hot, and so the proteins have denatured. So SD plasma thawing it has created some issues for our blood banks. And these issues of the cloudy and the clumps and the particulates have cropped up when the product has been thawed and then put in the fridge. And so the manufacturer has put out some additional information that you can actually, once you've taken it out of the fridge, rewarm it in the water bath to 37 degrees, and this should go away. So that's something that blood banks are dealing with. The bottom line for you administering the transfusion, you don't want to transfuse anything that's cloudy, has particulates, precipitates, clumps, or deposits. So it should be clear. And this is checked in blood bank, but it is part of the checking process that we use before administering a product. So we're going to move on now to talk about tubing, filters, infusion rates, monitoring, and adverse effects. So this is a busy slide. Basically for FP and SD plasma, it's the same. You need to use blood tubing with that 170 to 260 micron filter. You can use the filter for generally 4 units, 4 hours, whichever comes first. You can give them both at the same time, FP or other blood products. The compatible fluid is saline. You can prime the tubing with saline or plasma. No medications are compatible with either form of plasma, and all of these devices can be used as long as they've been approved on Health Canada's medical device regulation approval, and your hospital is maintaining them. So we'll go back to our patient, Freddie. So our blood bank has issued SD plasma group O. When you're transfusing the SD plasma, best practice is to infuse at 50 mils per hour over 4 hours. Yes or no? And I'll give you a chance to reply there. And most people have said, no, that's not really best practice. And it certainly, it could be done. 50 mils an hour, 200 mils over 4 hours, that would work. You could do it. It's just, if you're transfusing 4 units, you're looking at a minimum of 16 hours to transfuse that plasma. So that's probably not what you want to do and not in the patient's best interest. So this would not be what you would want to do. What is the infusion rate? So again, if it's not a massive hemorrhage protocol, it's always best to initiate transfusion cautiously and slowly. So for the first 15 minutes for adults, 50 mils an hour. For kids or neonates, 1 mil per kilo per hour, up to 50 mils per hour. I do want to point out, if you prime the tubing with saline, then you have to reprime it with plasma or with any other blood product that you might be infusing to ensure that slow rate is infusing the blood. Again, same as usual. After 15 minutes, assess the patient, check their vitals. If everything's okay, increase to the rate ordered. And you do want to administer plasma right before the planned procedure, if it's for a planned procedure, because the clotting factors do have, there's some variability in their half-life, but in particular for factor 7, the half-life is 3 to 6 hours. So you do want to have it just before your procedure. How fast can you give it? FP, the circular says over 30 to 120 minutes, maximum 4 hours from time of issue. And for SD plasma, best practice is as for FP. Now, there is some more information in the product monograph. It does list a maximum of 1 ml per kilo per minute. So for a 70 kilogram patient, you could give 1 unit in 3 minutes as your maximum, according to that. And in rapid infusers, they will actually give it faster than that. So there's been a lot of discussion regarding this maximum in the product monograph and what's safe to do. And the concern that the monograph has raised is about citrate toxicity, because the citrate anticoagulant, it binds calcium and can cause a low calcium and problems of hypocalcemia. So the concentration of citrate in SD plasma is very similar. So this really isn't, in SD plasma and FP is similar. So this really isn't a new situation. And NAC has gone on to say that in MHP scenarios, the benefit of the rapid infusion outweighs the risk of citrate toxicity. And MHP's protocols, most of them will have giving added calcium as part of the MHP for coagulation reasons. The other part about the infusion rate is TACO risk. And in Bloody Easy 5.1, this attention is made very prominent. Patients receiving plasma are at high risk for TACO. And we need to talk about TACO because it is the leading cause of transfusion-related deaths. So we do want to prevent TACO as much as possible. It happens because the transfusion is at a very rapid rate, or the patient's cardiac capacity is unable to tolerate the transfusion fluid volume. And plasma, the transfusion fluid volume is high, as we've seen from the dose calculations. So we do want to look at our patient to see if there's any additional TACO risk factors. And TACO prevention strategies, unlike red cells where you can transfuse only 1 unit at a time, that's not feasible for plasma, that's not the right dose. So you do have to try and transfuse it a bit slower or give pre-transfusion diuretics if it's not an acutely bleeding patient. If you've got a bleeding patient, then TACO is not likely as such a concern. But in someone who's not bleeding, we do have to watch for that. So we'll go back to Fred one last time. So Freddie, he's now got about 3.5 units of his SD plasma. His wife is there and she's finding him to become quite short of breath. So the nurse comes to assess. And so immediately, first off, Freddie's nurse should check his vital signs and call his doctor. And I will give you a choice of yes or no there. And we're pretty much 50-50 here. And yes, Freddie's nurse should check his vital signs and call his doctor. But no, that's not the first thing that should be done. The first thing whenever you suspect a transfusion reaction with any blood product is to stop the transfusion. So no different for FP. Stop the transfusion is always the first thing. And then the standard care that you would use for any transfusion reaction is applicable. So, keep the IV going, check their vitals, verify the patient identification, call the doctor, whatever patient care is ordered, and then, of course, report the reaction to the blood bank because they need to know they are responsible for reporting transfusion reactions, and certain reactions have to be reported to the manufacturer, Canadian Blood Services, and Health Canada. And of course, you want to document all the details. This is the standard Ontario acute reaction chart. Your hospital's one may be a little bit different. There are links to it here. It's a 2-pager because there's signs and symptoms of fever, urticaria, dyspnea, or hypotension. This side lists the signs and symptoms. On this side of the chart is the recommended investigations and suggested treatments. So I'll leave you with that to review or to look at your hospitals. And finally, in summary, this is a link to the transfusion checklist. And when you go through the checklist, you can see that all of these things apply for FP or SD plasma, just a few differences between how you execute these requirements. And so now we'll come back to these knowledge questions. So again, the first question the transition to pathogen-reduced plasma provides an additional layer of safety to Canada's blood supply system. The additional safety includes A, decreased risk of allergic reactions, B, inactivating all viruses, C, inactivating all bacteria, or D, this is a pooled product and so patient or recipient blood group testing is not relevant. I'll give you a moment to reply. And yes, indeed, the correct response is decreased risk of allergic reactions. It does not, solvent detergent treatment does not inactivate all viruses. It's only the lipid enveloped viruses, does not inactivate all bacteria, and ABO blood group is relevant for plasma transfusions, including SD plasma transfusion. Our second question, Emma, our young female trauma patient in your emerge with an active massive hemorrhage protocol and a blood group and screen test that is not yet completed. Select the SD plasma, or plasma for that matter, blood group to be transfused. So is it group O, Rh positive, group O, Rh negative, C, group AB, Rh negative, or D, group AB, Rh is not relevant for plasma transfusion? And again, I'll give you a minute to consider those options. And most people, not by much, but most people have selected group AB, Rh is not relevant for plasma transfusion. That is correct. That is the correct answer. Group AB, Rh negative is close, just that you don't need to know the Rh. Group O, Rh negative, that would be for a red cell transfusion. And again, if you want to go back to the slides on compatibility and look at the additional information about compatibility, that could help you there if you struggle with the answer to that question. And finally, the third question, when transfusing SD plasma, visual inspection of the product is not necessary. Some visible particulates or clumping is okay. It's compatible with all IV fluids, saline, dextrose, ringers. C, use standard blood tubing with that 170 to 260 micron filter, or D, infuse as quickly as possible. The half-life of coagulation proteins is less than 30 minutes. And I'll give you a moment to reply there. And the vast majority have selected C, use a standard blood tubing with a 170 to 260 micron filter, and that indeed is correct. Visual inspection is always necessary, and particulates or clumping is not okay. It is compatible only with saline, and infusing as quickly as possible would only be in a massive hemorrhage protocol. For a standard transfusion. You would not want to do that, again, because of the TACO risk primarily. And with that, I do want to give acknowledgement to the Ministry of Health, because they do provide funding for ORBCON, and as well to my ORBCON and transfusion medicine family and friends for their ongoing mentorship and support. I do have some references for you. In particular, these last two references are the NAC documents, and I would strongly encourage you to have a look at those documents. They're very helpful. And now at this point, I will entertain any questions that we might find in the chat. I do thank you for your attention and hope this was informative. Okay, there are a few questions. Our first one, how many times can you rewarm the SD plasma after thawing? That is a very good question. There isn't anything specific in the monograph that says how the frequency of rewarming or the additional information that provided the rewarming. It doesn't say how often you can do it. From talking to several hospitals, most rewarm it only once. And to me, that makes sense, but there isn't any written documentation regarding that. There is a second question about FDP, thoughts on the use of FDP. Freeze-dried plasma. At this point, I don't think it's available from Canadian Blood Services, at least not for general hospital transfusion. It might be available to the military. I'm really not sure, so I don't have any comment there. Certainly, if it would be very good if it could reconstitute easily. Another question, anesthesia rarely hangs normal saline for blood products. What is the reaction or the concern between plasma and ringers? It's the calcium, because the citrate anticoagulant in any blood, not just plasma, binds calcium. So there's a potential for a decreased calcium level and hypocalcemia. And that's really, that risk is really significant only in the setting of a massive transfusion where a great deal of blood units are being transfused. And in massive hemorrhage protocols, giving additional calcium and monitoring calcium is part of the protocol, so it's covered there as well. In terms of transfusion medicine standards, they do specify that you should only use the IV fluids that are considered compatible based on the product monograph, or if they've been proven compatible with some other test results. And as far as I know, there's not a randomized controlled trial or other documentation that says it's okay to use ringers. I know it does happen a lot of the time. In the operating room, it's mostly the anesthesiologist who's administering the transfusion. So certainly physicians have more leeway in their practice. But as a nurse, when you receive the patient in the ICU or in the recovery, I would recommend that you switch over to saline right away if you're running blood products, because that's what the monograph says and that's what you're covered to do. Another question, in the event that a patient requires all three, plasma, platelets, and packed red blood cells, is there a specific order to administer as per best practice? That would really depend on the patient's clinical scenario, and you'd want to probably seek some guidance from the order, from the prescriber, in terms of what's most critical in the particular patient scenario. It would likely be happening in a massive hemorrhage, and if the patient has already had 4 units of red cells, maybe the prescriber and the clinical situation might deem that the plasma should be given next. So it really would depend about the patient scenario. If you're asking about this question in the context of using tubing, platelets should always be transfused not necessarily first, but through new tubing. So they should be the first product to go through that transfusion set. And then the guidance that I go back to is usually 4 units or 4 hours, whichever comes first. Your hospital policy may be a little bit different, so do check that. There is now some more information in the chat regarding the freeze-dried plasma, and it says it's only available to the ministry, and at this point, some studies are being conducted. So I thank the person who provided that information for us. We do have one last question. Do we have information on cost comparison for FP versus SD plasma? I do not have that information. I don't have access to that. I'm sure, though, that cost was a factor under consideration in Canadian Blood Services plan for SD plasma. And they would, of course, be negotiating and in contact with the provincial and territorial ministries of health in that regard. The plasma that we're not using, because we're using SD plasma, that plasma will be going for fractionation for the manufacture of IVIG, albumin, other manufactured products. And certainly IVIG is a very costly product. I do trust that cost was carefully looked at in this proposal. I do hope that your questions have been addressed. If you have any additional questions, certainly feel free to email me. I do encourage everyone to complete the evaluation survey. That link will have been emailed to you because we do use that feedback in planning future events. This slide is a save the date with the dates for events in 2024, and that's also found on the Orbcon website, that information. And finally, I do want to thank everyone who's been involved with this event, the organizing committee, the speakers, the moderators, and most importantly, thank you to everyone who has attended and given up part of your time of your busy day. We hope that the information was informative and helpful to you. And I do thank you for your attention. And at this point in time, we will close.